right. Uh, Good evening, everyone, and a very warm welcome to the JMitra Scientific Webinar on the subject of benefits of POCT for rapid detection of dengue fever. We are delighted to have you join us today for a highly relevant and timely discussion subject. As we all know, dengue continues to pose a significant public health challenge, especially during the monsoon season, and the monsoon is upon us. While rapid and accurate diagnosis is critical to early intervention, clinical management, and even reducing the burden on our country's healthcare systems. In this context, point of care testing or POCT has emerged as a powerful tool enabling early detection and even in resource limited or high patient load settings. Well, today's session aims to provide deeper insights into the clinical advantages, practical applications, and the public health impact of POCT in combating dengue. It is my honor to introduce a highly respected field in the field of diagnostics and laboratory medicine, Professor Ashok Rattan. Professor Rattan is a renowned microbiologist and a public health expert with decades of experience in infectious disease diagnostics. He has held senior positions across academia, policy-making bodies, and the diagnostic industry. He continues to be a driving force in the promotion of high-quality, accessible diagnostic solutions in India and beyond. Well, we are privileged to have him with us today and share his deep expertise and perspectives on how POCT can truly transform dengue detection and management at the grassroots level. With that, I now invite Professor Ashok Rattan to take us through today's presentation. Over to you, sir.
Thank you, Arjun. As you know, monsoon brings relief from heat and children enjoy it. But along with the rains, there's also an increase in mosquitoes and flooding. As you wade through water while going to school or office, you are at increased risk of picking up leptospirosis, but that we'll discuss on another day. Today, we are focused on dengue. Dengue is transmitted by mosquitoes, which are also known as tiger mosquitoes, because they breed in fresh water and on the surface of the body are spots, as you see on the left side. This comes after monsoon, especially in the north, and will transmit a number of viruses, while dirty water is suitable for Anopheles, and Anopheles, as you know, transmits malaria. As there is monsoon, there's also a spike in the number of acute fever cases. In Delhi NCR, over 54 households report at least one member with high fever. Pediatricians are seeing 10 to 20 cases per day of high-grade fever in children, often with cough, sore throat, and fatigue. Indian Association of Critical Care in 2014 had a conference in which they decided that all acute fevers could be classified into one undifferentiated fever, fever with rash or thrombocytopenia, fever with acute respiratory distress syndrome, fever with encephalopathy, or fever with multi-organ dysfunctional syndrome. As you noticed here, the fever with undifferentiated fever, that means there's acute fever, but there's no other differentiating sign, is present in dengue, malaria, typhoid, leptospirosis, scrub typhus, and chikungunya. And each one of them can be fatal. WHO indicates that last year there were 14.1 million dengue cases. Globally, about 9,404 deaths. Dengue fatalities were higher, 5 times higher in the southern than in northern hemisphere. And as there is no specific treatment for dengue or severe dengue, early detection and access to proper medical care lowers fatality rate from 20% to below 1%. In the world, it's been noticed that over the years, dengue incidence has increased 30-fold. In India, dengue is always present, especially during these months. And from July to August, you see a peak every year. Just yesterday, there was a news heading in Times of India. When I went to the WHO website, where they have a dashboard, the information is provided from January 2025 to June 2025. And they mentioned that there are 6.6 million cases of dengue. 12,000 of them have been severe. 1.5 million were confirmed, and total deaths were 2,244. When I looked at 3.6 million and tried to tease out where the problem was, it appeared that more than 2 million cases are occurring in Brazil. That reminded me of our own Delta syndrome, Delta outbreak that we had, which occurred a few months after Brazil had had the problem. When you look at till May, you find that it was 3.4 million. So there have been about 200,000 cases in the month between May and June. Dengue is an RNA virus. It's a single-stranded RNA virus. It has 4 serotypes. Its size is 40 to 60 nanometer, and it has 11 kb genome. It produces one polypeptide, which then is broken down into 3 structural proteins and 7 non-structural proteins. The clinical features of dengue varies from completely asymptomatic to fatal. It has 3 phases, 3 clear-cut phases. One phase, the first phase is the febrile phase, when a person has acute rise of fever and high fever. As the fever subsides, instead of feeling happy, we should be forewarned that we are entering a stage known as the critical phase. Nothing may happen, but this is the phase where there's leaking of blood vessels leading to shock or bleeding from capillaries leading to hemorrhages. So both severe stages of dengue occur during the critical phase. If a person survives this critical phase or it passes through without event, then there is full recovery, and there is protection against the virus, against the serotype that had caused infection. So the first phase we are scared of, because of high fever, we are scared of dehydration. In the second stage, as I mentioned, is the critical stage where shock, bleeding, and organ impairment can occur. In the third stage, which is the recovery stage, the fluid which has leaked out is reabsorbed. And then, because of fluid overload, a person may still suffer. So, overall, it appears that since there are four viruses, and one virus will give protection against that serotype, that is lifelong protection, but it makes you susceptible to the other three. And there is something known as antibodies enhanced damage. So the primary one is very mild and may be asymptomatic. Is the second attack, and you are prone to three dengue secondary attacks. That is the time when the risk of severe illness and death becomes more. So, in biology, of course, nothing is 100% this or that, but there is consensus that the first dengue infection rarely develops severe disease or recovery, and there is recovery. When the second infection occurs, then the chances of severe disease manifestations associated with fatality are more. And this is because of something known as antibody-dependent enhancement. This antibodies-dependent enhancement is that when the virus enters the blood and enters the cell, it multiplies within the cell. Subsequently, this leads to generation of antibodies. These antibodies are protective against the virus, and they will neutralize the virus, and they will be phagocytized by macrophages and monocytes and will be removed from the circulation. These antibodies they provide lifelong immunity against the infective serotype. Protection against other three serotypes is transient, and in fact, non-neutralizing antibodies are produced, which when second attack occurs, instead of neutralizing, it will bind to the virus, the new virus, without neutralizing it, and then it will facilitate the entry into macrophages, where instead of being lysed, it will replicate. As a consequence, there will be high titer of the virus.
Plasma leakage is a process in which the protein-rich fluid component of the blood leaks from blood vessels into the surrounding tissue. Plasma leakage is the most serious complication that distinguishes dengue from severe dengue. For some dengue patients, as fever begins to disappear, severe dengue will develop.
So NS1, which binds to toll-like receptors, would then lead to production of TNF-alpha, of IL-1 beta, and IL-6. This cytokine storm leads to plasma leakage and decrease in platelets. It's also been documented from Indonesia that there is correlation between the presence of non-structural protein 1, NS1, and the severity of infection. The higher the level of NS1, the more is the severity of infection. You would notice here in the time frame, when the fever decreases, and we feel happy that the fever has decreased, that is the time when platelets may also start decreasing. And this will lead to bleeding tendencies. Or the blood starts leaking from the capillaries, and this will raise packed cell volume, leading to shock. Recently, in Nature, it was indicated that in primary infections, the NS level was much higher than in the secondary level. Because in the secondary infections, the patients already have IgG levels, and IgG will bind to NS1 and decrease the level. But as you notice here, that the level of NS1 varies from 1 nanogram to 1 to 2 grams per ml. And naturally, if it is high level, that is the time when the chances of severity increases. So the causes of death that it causes, one is unrecognized dengue without appropriate medical management, unrecognized or prolonged shock, unrecognized occult hemorrhage, fluid overload, nosocomial infections, and liver failure. So these are the common causes that have been listed. A study in Patna indicated that dengue was the commonest cause of fever during monsoons. This study concluded that early referral can lead to minimize the morbidity and death related with acute febrile illness during monsoon and post-monsoon period. A study for Maharashtra also indicated that dengue fever was present in majority of patients presenting with fever during this time. Dengue fever in Delhi have also been reported every year, and sometimes it's at a peak, other times it is lower. Though the burden of disease study had indicated that from 1990 to 2019, the incidence of dengue has increased, and the disability adjusted life years, which was 16 years in 1990, are now 28 years. This is the morbidity and mortality that we lose because of dengue infection. So in 2019, it was 28 years that in India and an Indian may lose as a consequence of dengue fever. Average infection reported is about 0.115 million, but the projected based on global burden of disease data is 5.7 to 33 million. In 2010, Nature had reviewed the diagnostics available, and they had wrongly drawn the analytes as they move. You will see that this is published in Nature, and there's a wrong prediction of how antibodies move. At that time, they had mentioned that the test available was virus isolation which no longer is practiced except for reference lab, genome detection by RT-PCR, which is available, antigen detection NS1, serology IgM, and serology IgG. As you noticed that they have mentioned that virus isolation was the most specific, but the opportunities was maximum of finding out IgG, which would only be for surveillance. Subsequently, in 2020, April 2025, WHO has brought out laboratory testing for dengue virus and interim guidelines. In this, they say that the primary and secondary dengue infection exhibit distinct diagnostic pattern. In the primary infection, viral RNA and NS1 antigen are detectable in the acute phase, while IgM peaks around 2 weeks and subsequently declines, and IgG appears later but persists longer. One thing is to be clear that IgM appears after 3 days of clinical symptoms. So if you collect the sample early and send it for IgM, which many in the world do, you would get a false negative result. In secondary case, viral RNA remains detectable, but NS1 antigen detection is reduced due to the formation of antibody and antigen complex with pre-existing antibodies. IgM is reduced or absent, whereas IgG rises early and dominates the immune response. High IgG levels combined with viral RNA, NS1 antigen, or IgM suggest secondary infection. IgM IgG ratio may aid in the differentiation of primary and secondary, though I would suggest something else. But you noticed that between the two, there is NS1 which is present from day 1 or day 0 as you call it. When the clinical features appear, NS1 is present. Viral RNA is present before that. Viral RNA will disappear in 5 to 7 days, while NS1 is present in primary for 9 days. And in secondary, viral RNA is present, NS1 is at a lower titer, and it will disappear in about 6 days' time. But in the first week of fever, dehydration is the potential medical death. This is the only damage that can occur if you make a diagnosis early and are pre-warned. If it is missed during this time, then in the critical phase, there could be shock and there could be organ impairment. So WHO had also mentioned that there could be 3 types of tests, 3 types of reasons why you do the test. Our interest is early diagnosis so that the appropriate prevention and treatment can be initiated. This will distinguish between dengue and other causes which have similar clinical presentation. As I had mentioned, if it is not dengue, it may be malaria, it may be leptospira, it may be typhoid, it may be scrub typhus, and it may be chikungunya. So that if it is dengue, then it is confirmed. But if it is not dengue, then these are the 5 other causes which have similar clinical features. Since NS1 is the one you're looking for, then the levels are level of NS1, as I've indicated, indicate the severity of the infection that you have. And the severer the infection, the higher is the level of NS1. It provides results in 20 minutes. Point of care testing will provide results in 20 minutes time. It is relatively inexpensive, and as I will demonstrate, it is easy to use, and the kits are stable at room temperature or temperature greater than 30 degrees Celsius for field use if necessary for years. The other tests which may be of interest and which NCDC normally insists upon is for epidemiological surveillance and for outbreak investigations, which is you can have first priority and second priority. And here maybe PCR as well as NS1 may not be appropriate. It is antibodies which will be appropriate. And the third will be vaccine efficacy trials, which you want to know whether a person has already had infection and whether now antibodies are produced against all four, because it is clear that if the vaccine does not simultaneously protect against all four, then the vaccine can cause more damage than good. Recently, it has been noticed that Aedes aegypti has a viral they discovered that there is a locus known as LOGS2, which is a newly discovered element of antiviral defense of Aedes aegypti mosquito. It plays an important role in controlling dengue and Zika virus during their systemic dissemination within the virus. However, it has no effect on infection within the intestine. And so dengue can be transmitted by the mosquito to other persons without Aedes aegypti becoming infected itself. Dengue, clinically, WHO in 2009 had indicated that dengue could be with warning signs and without warning signs. This is warning signs of severe dengue. And when we end our talk, I will give you the 4 things to look out for. In this edition, in 2025, WHO now has indicated that this is the algorithm which you can find for the laboratory testing for dengue virus. It says that when you suspect dengue case, you must find out how long the symptoms have been there. If the symptoms are less than 7 days, then the options you have is to do either RT-PCR, so you can detect NAT, that is nucleic acid amplification test, or you can do NS1. NS1 you can perform by ELISA or by rapid diagnostic test. So here is the first indication that the WHO agrees that rapid diagnostic tests are useful in identifying dengue cases of less than 7 days duration. If the duration is more than 7 days, then you can do either ELISA or a rapid diagnostic test looking for IgM. And if you're not sure, then the best is to use both NS1 and IgM. ELISAs have to be done separately, so 2 ELISA tests have to be done, while if you do rapid diagnostic tests, then you have combo which will detect NS1 and IgM simultaneously in 2 minutes time. And this is the recent algorithm suggested by WHO. Whenever there's a spike of fever, hospitals become overcrowded and patients have to wait a long time. While both the patient and the doctor hope that they can do a point-of-care diagnostic platform which can distinguish rapidly, easy to use, and require minimal equipment, making them suitable for low resource setting so that it can help in deciding which treatment needs to be initiated and the treatment depending upon whether it is mild, where a person can be treated at home, or moderate or severe, where the person must be admitted, is decided. But that all follows diagnosis of dengue. Of course, one wishful thinking which people have, especially after COVID, is that if they can do the testing themselves, if the testing can be hassle-free with no special equipment needed, fast, results available in 20 minutes time, easy sample preparation so that no complication is required there. It should be reliable so that you can believe on the positive and the negative results, and the amount of sample required should be minimal. So home test could be of three types. One is that you test the entire process yourself. That makes it simple to use. It makes it easy. You can do it anytime at the convenience of your house. Second one is that you get somebody to come and collect the sample from your home and then transfer the results electronically. And the third one is you confirm, you book the appointment and go to the lab to get the test done. In the test available, nucleic acid detection is the most definitive after culture. Of course, as you know, culture is done only by research labs, and we are not interested in a routine testing. RNA detection by RT-PCR is highly sensitive and specific. It is relatively rapid, giving results in about 3 to 4 hours time. It's possible to automate and can identify what species. As you know, as I said, there were 4 different genotypes, serotypes. So you can identify the serotypes by using nucleic acid amplification tests. But the limitations are that it is positive only in the first 5 days. It is positive 1 day before the person becomes sick, but you will not test during that time. Only when a person has shown symptoms would a sample be taken. Then it is present only for the first 5 days. So if it is not tested quickly, then it will not be much use. It requires about 0.5 ml of sample. Then it needs trained staff. Of course, point-of-care testing is available nowadays. And this is one example of a diagnostic test which can detect not only dengue 1, 2, 3, 4, but also Zika and chikungunya. And it will give you results within 30 minutes. This is a cartridge-based test, which is simple to use. It will amplify and give you results. But as I said, the advantage is it can do the results in quickly, but it will require only in the first 5 days. For public health use, next generation sequencing or whole genome sequencing could be useful because it will be useful for surveillance and for characterization of the virus. But this also will be useful only if the sample is collected in the first 5 days. So public health authorities have to collect the sample during the first 5 days. That's the time when the virus is there, unless they have done the culture, and then they can do from there. So the practical test which a person can do for clinical diagnosis is NS1 antigen detection by a rapid test, which will be a surrogate of viremia. The advantage is NS1 is highly conserved. It is same in all the four. So all four species would be detected, but you will not be able to differentiate between serotype 1, 2, 3, or 4. But you can detect. Results are available in 30 minutes time, and the level of detection is 1 nanogram per ml. As I told you, many of the infections would be 1 nanograms to 1 gram. So when a person has severe infection, there'll be high levels. So there would be a few cases which might be missed because the level of NS1 is less than 1 nanogram. But any serious case would have much higher level and would be detected. This also has the same advantage of being positive in the first 5 days. As you notice here, there's also a self-test which you can do at the comfort of your own house. It detects all four species. It's reliable for primary and secondary infection. It has shelf life of 30 months at 30 degrees Celsius, and it takes only 1 drop of blood.
This is your dengue home test kit. It includes a test device, an assay buffer tube with nozzle, a sample dropper, swab, and a lancet, a disposal bag, and an instructions manual. Rub your fingertip with a swab. Gently prick the fingertip with the lancet. Use the sample dropper to draw the blood into it. Add 1 drop of whole blood sample into the sample well of the test device. Add 1 drop of assay buffer into the same sample well. Allow reaction to occur for 20 minutes and read result. The result is positive when 2 distinct pink lines appear in the control region C and test region T. The result is negative when only 1 pink colored line appears in the control region C. The result is invalid when neither control line C nor test line T appears, or only line T appears. Repeat the test again with a new card.
So you see that you have NS1 antigen detection test, which can be rapid, a POCT, which can be done. There's also NS1 ELISA, which have the sensitivity of 500 picograms, which is twice the sensitivity of NS1, which has the limit of detection of 1 nanogram. This is highly conserved, and it has the same advantages that NS1 has. The disadvantage is that normally ELISA is batched because it takes 3.5 hours. So you start doing the test. You do the test normally once in a day, rather than as and when it is required. Then it's normally manual, though these automated watch systems are available, and it is accurate. And up till now, it has been the reference lab, a reference which people have been used. But for serological testing, it is best to have 2 samples and to show tighter movement. 2 samples must be collected 2 weeks apart. Now, that is not possible in diagnostic testing, and that's why ELISA has its own difficulty. The other option is that if we are not sure about how long the patient has been suffering, if there's any doubt, then you should detect both NS1 as well as IgM. As I had mentioned earlier, IgM does not appear for at least the first 3 days. NS1 is positive for 5 days. So if a person is not clear, then it's best to test both of them together. And that is possible by using a duo test, a rapid test, where you will detect NS1 or IgM. And whether it is for 5 days, where NS1 will be positive, or for 3 to 5 days, where both NS1 and IgM will be positive, or subsequently more than 6 days, where only IgM will be positive. This rapid test will give you reliable results and results in 20 minutes time. In a study which was done and published from Singapore, the sensitivity was found to be 92.4%, specificity was 98.4%. So, depending upon whether it is primary or secondary, this, as you know, primary has less chances of being followed by severe infections, though there is one study which indicated that it's possible to have severe disease even in primary. But it is of interest to identify whether the infection is primary or secondary, but there is no test available except if you interpret the results like this. If there's NS1 and IgG, not IgM, NS1 and IgG, if both are negative, then the person doesn't have dengue fever. If NS1 is positive and IgG is negative, this is primary infection. If NS1 is positive and IgG is positive, then this is secondary infection. And if NS1 is negative and only IgG is positive, then a person has previous infection and this is not a current infection. So combining NS1 with IgM ELISA, you can do the testing, but again, NS1 is tested separately in ELISA and IgM is tested separately in ELISA. That means you're doing 2 tests. Then they are batching of the test. That would mean that the result will have to be given to a central lab and the report will take at least a few hours before it is available. And so instead of doing one test in getting the information, you would have to do 2 tests with the additional cost involved. Initially, they also used to have IgG and IgM together, and this has an advantage. This will be negative in the first few stages, but it will be useful later on. So for surveillance, especially in resource-limited condition, it may be useful. Again, IgM and IgG, there will be 2 different tests by ELISA. This will be useful for surveillance, but for early patient management, this will be counterproductive. So the WHO then suggests that in acute infections, in the first 7 days, either you do RNA or you detect NS1. Either you use ELISA or rapid test. And if the result is positive, it will confirm that a person has acute dengue infection. If acute infections and convalescent is not clear, then you should do NS1 plus IgM. And if it is more than 7 days, then you do only IgM. As I was trying to tell you that up till now, people have been following ELISA as the gold standard. But here you find that the gold standard will detect about 500 picograms of the antigen, while chemiluminescence will detect 1 picogram of antigen. So ELISA is good because antigen that you have is 1 nanogram to 1 gram. So it's much, and NS1, if the sample is collected at the right time, it is much higher. But if the sample is not collected at the right time, then ELISA may not be useful and chemiluminescence will be better. You will find that chemiluminescence has many advantages over ELISA. Sensitivity is excellent in chemiluminescence. The dynamic range is broader. It is fully automated. You can have random access. The turnaround time becomes 30 minutes. Cost is higher, but the results are more sensitive. And of course, if you have something which is as sensitive as 1 picogram, then you might find, I will make that point later. So there is one lab which has already shifted to using benchtop CLIA, and they find that that all the advantages that are listed are realized. Now, WHO indicates that the virus is present in the plasma, in the whole blood, in capillary blood, in urine, and in CSF. So if you have a test which can detect 1 picogram instead of 500 picograms, when the method is so sensitive, then maybe instead of blood, you can use non-invasive samples like urine or saliva in children to find out whether the fever that they have is because of dengue or not. WHO has also indicated that the point of care testing should meet the assured criteria. That means they're affordable, they're sensitive, specific, user-friendly, rapid and robust, equipment-free, and deliverable where they're required. Recently, the assured has become reassured by adding real-time connectivity and environmental friendliness. And you will notice that the point of care testing that I have described fulfills these criteria. So what are the benefits of point of care testing for dengue fever during monsoon season? One is rapid diagnostic for timely intervention, accessibility in resource-limited settings, decentralized testing for outbreak control, enhanced patient management and triage, and cost effectiveness. The attributes which make point of care testing not only outside the hospital but also at home is high sensitivity and specificity. Its requirement must be more than 75% sensitivity and more than 98% specificity. As I indicated, that the sensitivity of many of the good NS1 tests is about 90%. And the more severe the infection, the higher will be the NS1, so more likelihood of being picked up. They're easy to use, as you notice, 1 drop of blood, 1 drop of buffer, and in 20 minutes time, you have the result. They should be stable, and you notice that the kit is stable at 30 degrees Celsius for years together. Turnaround time is 20 minutes time. You can do it anytime. There is, it doesn't matter whether the shop is open or not. Portable and minimal equipment. So you have to worry about safety and biosafety, but this is one finger prick. Normally, it has been recommended that you should be using the ring finger rather than the index finger or anywhere else. And instead of using the tip of the finger, you should use the side of the finger. So even the single prick that you use will not be painful. Why ring finger? Because the tendon on the ring finger is enclosed in a sheath which is limited to ring finger, while tendon in other fingers are enclosed in sheaths which are common, so that God forbid if there's any infection, it will be localized to the ring finger. But yes, there is because finger prick blood is involved, so you should pay attention to disposal of the drop of blood, and make sure that you are using spirit to clean your hand so that infection doesn't occur. Another point I would like to stick my neck out is if we rely on ELISA for lab diagnosis, it is counterproductive. It is time-consuming process. It depends on laboratory infrastructure. There is cross-reactivity possible, inability to support decentralized testing, limited utility in early diagnosis, cost and resource intensive, and in challenges in outbreak scenario. There is batching of samples, so the results are not available quickly. I remember when I was in Jaipur, we would test every day, get the address, and next morning when we talk to the public health authorities, we will share the address of persons who were positive so that fumigation could occur. So similarly, in case of dengue, there should be fumigation and vector control the next day in whatever locality these infections have occurred. Okay, then the counter argument is that ELISA are highly sensitive and specific, make it indispensable for confirmatory diagnosis, especially in complex cases involving secondary infection or co-circulating flaviviruses. While this is valid, POCT technologies like RT-PCR and multiplex LAMP assays have achieved comparable accuracy provided the sample is collected at the right time. ELISA's logistic constraints overweigh its precision. Its resource limited setting, where POCT practicality and speed are more impactful. Another argument is that POCT's variable performance, sensitivity is low for NS1 in urine, etc., can be overlooked by using the test. So there is something for POCT and something for ELISA. POCT will revolutionize dengue diagnosis during monsoon season by offering rapid results, making it accessible in far-off places, and decentralizing the solution. It will lead to timely intervention by the clinician as well as the public health authorities. It will improve access in resource-limited setting. It is effective in control of outbreaks. It will give the doctor to be able to identify persons at higher risk better. So this has been already mentioned, and the carry-home message I would like to say is that rapid NS1 POCT is valuable test for early diagnosis in dengue fever due to speed, accessibility, cost effectiveness, particularly in resource-limited setting, and it has been endorsed by WHO in the 2025 algorithm, which is enclosed. In the recent past, scientists have also been working to enhance the sensitivity of POCT, and the reports indicate that they have a limit of detection has been lowered from 1 nanogram to 10 picograms. And so they are nearly as sensitive as PCRs. One study also indicated that by using two lateral flow, you can also identify the serotype of the offending organism. It's not only diagnosis of dengue that is important. Whenever there is dengue, you must also monitor platelet every alternate day and more frequently if you are admitted, and the packed cell volume. Also, liver function tests and kidney function tests. Both platelets and packed cell volume are very important because they are indicators of the impending dengue hemorrhagic syndrome or impending dengue shock syndrome. There was a study which was carried out in Vietnam but published from Australia, in which this is an evidence-based algorithm for early prognosis of severe dengue in outpatient setting. As I'd indicated, whenever there is an outbreak, the hospitals are full and you don't know whom to admit and whom not to admit. The risk is not when a person has high fever. The risk is higher when the fever has come down. And traditionally, Indians would like to go home when the risk has come down. So which person to keep in the hospital and which person to let go and let him be treated at home was this step, this test, which looks at whether there's vomiting or not, whether NS1 is positive, what is the level of platelets, and what is the level of AST. And giving different points to it, it collates the information, and if it is more than 35% risk, then a person must be admitted. The negative predictive value, when it is not 35%, then 99% is the negative predictive value. That means anybody whom you have let go home, none of them will suffer from any serious consequences. The flip side is that all those whom you have kept under observation, not all of them will suffer the dengue shock syndrome or dengue hemorrhagic syndrome. So the positive predictive value is 10%, but the negative predictive value is 90%. And that actually means you look at vomiting, give some points to that, NS1, give points, what is the level of AST and what is the platelet levels, and then you decide what is the risk factor. So as I promised you that from the WHO 2009, I will tell you the 4 things that you have to look for. Initial warning sign is disappearance of fever, drop in platelets, and increase in hematocrit. If the platelets are down, so first is during the fever, you must know whether you have dengue or you don't have dengue. And that you can do by doing a point of care testing. Once it is positive, then you would monitor your platelets and packed cell volume. If the platelets are falling and the hematocrit, that is packed cell volume, is increasing, that is the initial warning sign. The alarm signals are when there is severe abdominal pain, where there is prolonged vomiting, abrupt change from fever to hypothermia, change in level of consciousness, sometimes irritability, and sometimes sleepiness. When patients develop dengue shock syndrome, this is 3 to 6 days after onset of symptoms. 4 criteria for dengue hemorrhagic syndrome is fever, hemorrhagic manifestation, excessive capillary permeability, and platelets less than 100,000. So if you take these precautions and make early diagnosis using point of care testing, I think appropriate test would be done and the chances of suffering the consequences will be minimized. I thank you for your attention.
Thank you very much, Professor Rattan. Your presentations, as always, are extremely detailed and exhaustive in nature in terms of covering every facet of the subject on hand. So, thank you very much for your time, sir. Let me see if anybody has any questions. Okay, we don't have any specific questions to the webinar subject. But yes, I think POCT and home testing is the future moving forward, not just in dengue, but also in other areas of testing. What are the other areas, sir, that can be looked at from a home test perspective, given your experience, sir?
Sticking to this fever itself, as you know, there's malaria. So if it is dengue is positive, then it's fine. Otherwise, there's malaria, there's leptospira, there's scrub typhus, there's chikungunya, and there's typhoid. So all of them are amenable to to point of care testing. In fact, there was a time when we thought that we should be doing syndromic approach, so that instead of person thinking maybe this is malaria and doing the test, then getting the result back the next day, it's best that one sample and all the 6 causes of undifferentiated acute fever are tested together, and by 2 or 3 hours you have the result. It's only the cost. In the West, of course, they have all gone for it. So
They have even here, sir. I've seen a lot of cases where the doctors are always recommending a complete fever profile for the patients, which in fact covers a lot more than just the 6 tests. But yes, there is a cost factor, and India is a cost-conscious country at this point of time, you know. But thank you, sir. Thank you for your time and effort, and thank you, ladies and gentlemen, for watching and spending time in our dengue education series with Professor Ashok Rattan. Thank you, and Jai Hind.